Is there anyone who would like to volunteer to start the reading? I can
Yeah,
start. Sorry, somebody said something?
yeah. Sorry, I said I could start us off if you want.
Sure. Thank you, Greg.
Okay, massive bleeding. Some causes of a major bleeding episode may include cancerous tumor destroying large blood vessels, some liver disorders, clotting disorders such as thrombocytopenia. This is a condition caused by the blood containing fewer platelets than normal. Subsequently, a patient will have a longer bleeding time if she is injured or bleeds for any reason. Thrombocytopenia is a side effect of many drugs, including some chemotherapy medications. Major internal bleeding or hemorrhaging can occur if one's platelets count is extremely low. Major bleeding episodes may be accompanied by symptoms of anxiety, restlessness, and cool, moist skin that appears pale. Notify the hospice nurse if the patient has blood in the urine, hematuria, or bloody stools. Is vomiting dark coffee ground material, hematemesis, has uncontrolled nosebleeds, or any other kind of bleeding. As a caregiver, always wear latex or other medical gloves when coming into contact with any type of bodily fluid, either directly from the patient or on soiled dressings, clothing, or linens. Properly dispose of waste materials in large, heavy-duty trash bins that are securely tied. Immediately wash your hands with disinfectant soap and water after handling soiled material. It may be upsetting to the patient and family member to see large amounts of blood. If there is even the slightest possibility that your patient may have a major bleeding episode, have a hand-on emergency kit containing some red or dark colored towels to cover the blood, some dark washcloths, a small wash basin, a large plastic bag to put the used towels in, and a plastic cover to protect the bed. I've used a new shower curtain liner. They are expensive and large enough to cover a twin or full size mattress. Call the hospice nurse. Do not call 911 or your local emergency medical hotline. Stay calm and relax the patient while waiting for the nurse to arrive. Constipation. Constipation means difficult, irregular stools and is experienced by the majority of terminally ill patients. Prevention by treating it as a problem before it becomes one is a challenge all caregivers must confront. Patients will complain of hard-formed stools, inability to pass stool for at least 2 or 3 days, seepage of a small amount of liquid stool, diarrhea leaking past fecal mass, and mild to moderately tender abdominal distension. Constipation is often accompanied by nausea and vomiting. This can also cause anorexia, rectal pain, and confusion. Each individual varies, but as a general rule, a patient should have a bowel movement at least every 3 days. Constipation can lead to painful hemorrhoids as well as to fecal impaction, stool that remains in the rectum and is unable to be evacuated. The nurse usually has to disimpact the patient by manually emptying the rectum. This can be extremely uncomfortable for the patient, sometimes requiring administration of a pain medication before the procedure is performed. Occasionally, the impaction is higher up and hospitalization may be necessary to clear this type of complication. Even more serious is a bowel obstruction, stool that collects higher in the intestines. Therefore, it is recommended that the caregiver keep a written record of the patient's bowel movements. This may seem unpleasant, but the medical consequences of prolonged constipation are even more unpleasant. Common causes of constipation include side effects of medications, especially opioids, anticholinergics, and tricyclic antidepressants, decreased mobility, decreased fluid intake that reduces fluid in the colon, decreased fiber intake, dehydration, and improper use of laxatives, especially when taking opioids, either intermittent use or inadequate amount of laxatives. Does anybody want to take over at this point?
Is anyone raising their hand, or you can continue, Prabhu?
I can continue to a little bit later, that's fine. As soon as medications, as soon as any type of opioid is started, a laxative and stool softener regimen must be started immediately. If the laxative dose is too low or it is administered only intermittently, the patient will still experience constipation. Every hospice differs in its protocol and choice of bowel medications. There are, however, bowel medications that are more commonly used than others. Two effective medications that combine a laxative and a stool softener are Senecol S, Sena and docusate sodium, and pericolase, docusate sodium and casanthranol. Sena, is a laxative only without the stool softener, and colase, docusate sodium, is a stool softener only without the laxative. Taking it in combination form is obviously more convenient and decreases the amount of pills that need to be swallowed by the patient. Milk of magnesia is also administered at bedtime with a large glass of water, either as needed when already taking a regularly scheduled laxative or routinely as part of medication schedule. Isocodil suppositories, e.g. Dulcolax, are commonly used in a hospice setting. 1 or 2 suppositories are usually effective within an hour. Castor oil taken orally, it now comes flavored, is also an effective stool softener. A bulk forming agent such as psyllium, e.g. metammucil, should only be taken if the patient is drinking an adequate amount of fluid. Otherwise, it tends to increase the incidence of fecal impaction. If the patient becomes impacted, the hospice nurse may administer a mineral oil retention enema prior to disimpacting the patient. He or she may follow up with a Fleet's enema or a normal saline enema. Some nurses prefer to administer a milk and molasses enema. This formula is 4 cups of warm water mixed with 1 cup of powdered milk and 1 cup of molasses. Back to basics. Encourage an increase in fluids. Keep a pitcher of fresh water at the bedside. Serve warm prune juice. Encourage intake of fiber-filled foods such as bran. Bran should only be taken if the patient is drinking a lot of fluids. Otherwise, it will be counterproductive. Encourage an increase of fruits and vegetables if the patient is experiencing anorexia. Serve various fruits and vegetable juices. Make ice pops by pouring fruit juice in a paper cup. Place a spoon in each cup and freeze. If possible, encourage the patient to walk, even if he just walks around the room once or twice. He is bedridden. Simply by repositioning the patient every 2 hours, he will receive some benefits of mobilization. Serve higher fiber breads and cereals such as oatmeal. Diarrhea. Diarrhea frequent loose or liquid bowel movements is less common in hospice patients than constipation. It does occur though and can be accompanied by painful abdominal cramping. Causes may include incorrect doses of laxatives and stool softeners, undetected fecal impaction, early bowel obstruction, side effects of chemotherapy, side effects of medications such as antibiotics and some non-steroidal anti-inflammatory drugs, and intestinal obstruction caused by malignancy, steatorrhea, pale floating loose stools caused by malabsorption of fat, commonly seen in patients with pancreatic cancer, diet, including lactose intolerance, and pre-existing conditions such as colitis or irritable bowel syndrome that may exacerbate with anxiety and fear.
Is there anyone else who would like to continue? If so, please unmute.
Can do it.
Sure, thank you.
Medications. A patient should never be medicated for diarrhea if a bowel obstruction is suspected. If the patient has steatorrhea, the condition may respond to pancreatic enzyme replacement therapy, lipase, protease, and amylase. Loperamide Imodium is often given for diarrhea, even when the cause may be malignant intestinal obstruction. The steroid dexamethasone can also be administered for this situation. Pepto-Bismol and chiropectate are often administered to hospice patients as well. If Imodium, Pepto-Bismol, and chiropectate are ineffective, a prescription for diphenoxylate Lomadil is sometimes obtained. It is essential to balance a patient's laxative use so she does not get caught in the cycle of constipation caused by under medication and with the laxatives, and diarrhea caused by over medication with the laxatives. Use of laxatives and stool softeners can be tricky and may require frequent adjustments. Back to basics. Stop administering laxatives and other bowel medications until the diarrhea has stopped. Inquire from the hospice nurse about other medications being taken that may cause diarrhea as a side effect. Stop food supplements such as milkshakes that may cause diarrhea. Serve a clear liquid diet only until the diarrhea has stopped. Serve clear juices such as apple juice, sodas such as ginger ale, clear vegetable broth, water, or an electrolyte balancing sports drink. As a rule of thumb, a clear liquid diet is anything that you can clearly see through. Avoid milk products, non clear soups, and non clear juices. Never give prune juice when the patient is experiencing diarrhea. When diarrhea ceases, slowly increase diet to full liquids such as cream soup. Increase diet as tolerated to a soft diet and then to a regular diet. The patient's hospice nurse or physician should advise you as to when to restart the patient's bowel medications. If certain foods, such as products containing lactose, are causing diarrhea, keeping a food diary should help to solve the mystery. Keep a daily log of all foods that are eaten by the patient and when. Also, list each time the patient had diarrhea after eating. A pattern should begin to appear as to what foods, if any, cause diarrhea. Immaculate skin care is especially important when a patient has diarrhea because he is at a high risk for developing soreness, redness, or rash on the buttocks. If he is able to shower or bathe without assistance, provide a mild soap and encourage him to pat dry the area of concern rather than rub dry to decrease his chances of soreness. Whether the patient is independent with bathing or requires assistance after drying, the caregiver should apply a thick cream to the barak area to protect the skin. When in the US, I prefer Balmex cream. It helps shield the skin from moisture, is inexpensive, stays on for several hours, and a little goes a long way. It can be found at most grocery or drugstores. Dyspnea. Dyspnea means labored or difficult breathing. This may or may not be accompanied by pain, but is always distressing to the patient and to those watching. The patient may exhibit shortness of breath or exertion or at rest. Dyspnea may be accompanied by cyanosis, a bluish discoloration of the skin and or lips. Onset of dyspnea may be sudden or gradual and may or may not be accompanied by a cough. Causes may include extreme fatigue, pulmonary disease interfering with air exchange, such as chronic obstructive pulmonary disease, COPD, or lung cancer, either as the primary site of cancer or as lung metastasis. A growing tumor will usually cause gradual onset of dyspnea. Infections such as pneumonia, pulmonary embolus, and obstruction in the pulmonary artery, usually caused by a blood clot that has broken away from a lower extremity. This causes sudden onset of dyspnea. I have seen a few patients die suddenly when this occurred. Although it is an extremely serious condition, it is not always fatal. Heart failure resulting in pulmonary edema. This causes sudden onset of dyspnea. Anxiety may cause sudden hyperventilation, anemia, low number of circulating red blood cells, hemoglobin. The iron containing component of the red blood cell is less than that needed to supply the body's oxygen demands. Anemia usually causes gradual onset of dyspnea. The patient may become cyanotic. Can I go on? What can be done?
Sure.
Medications. Do you want me to go on?
Sure, thank you.
Okay. Medications. In a hospice setting, fast acting liquid morphine sulfate is usually the drug of choice for severe shortness of breath. Often, a low dose of instant immediate release morphine is all that is needed to decrease respirations and assist in making each breath more efficient. For dyspnea, morphine can also be administered via a nebulizer, a small device that produces a fine mist which is then inhaled. The nebulization of opioids delivers medication directly into the airways, thus entering the pulmonary circulation quickly. Advocate states that this route of administration causes fewer adverse effects such as drowsiness, nausea, vomiting, and constipation. An anti anxiety medication such as lorazepam, Arivan, can be dissolved under the tongue if dyspnea is caused by sudden feelings of panic. Lorazepam is also available in gel form to be applied direct.
Lorazepam.
What is that?
Lorazepam.
Lorazepam is also available in gel form to be applied directly to the skin. Some patients respond well to diazepam, Valium, bronchodilators such as ipratropium bromide, Atravan, or albuterol, example Ventolin, are often helpful and can be administered through an inhaler. Theophylline, Theodore, also bronchodilator, is commonly used with dyspnea, is caused by COPD. If dyspnea is caused by cardiac failure, the physician may prescribe a diuretic. Antibiotics may be needed if the patient has an infection, such as bacterial pneumonia. If the patient is responsive, be sure to ask him if he agrees to the use of antibiotics in the case of infection and if used for comfort. If he is unresponsive, abide by his wishes as stated in his living will. Back to basics. If the patient is in a hospital bed, the head of the bed should be raised to a 45 to 90-degree angle so the patient is in a sitting position. If she is not using a hospital bed, assist the patient in a sitting position by propping enough pillows behind her so her head and chest are raised. Reassure the patient that you will not leave her alone. If the patient is using oxygen therapy, be sure the nasal prongs are inserted properly. In a calm voice, remind her to feel the oxygen being inhaled with each breath. Provide a gentle breeze toward the patient's face by opening a window, using a small electric fan turned on low and facing the patient, or using cool mist vaporizer if dyspnea is accompanied by cough. While the patient is in a sitting position, assist him in pursed lips, breathing, see anxiety. Try to relax the patient with your calming voice as you talk him through this breathing technique. As he slows his respirations, perform pursed lip breathing with him. Then try slowly chanting the Maha Mantra as he continues to use this breathing technique or assist the patient in a meditation that will relax his mind and assist in slowing respirations.
I can read now if you like.
Thank
Okay. Somebody wants to read?
Yeah,
Or
thank you.
you sure?
You start.
Thank you.
Edema. Edema is swelling due to body
I can read.
tissues.
Thank you, Karnapurna Shakti Mataji. Maybe after Shalagram Mataji?
That'd be fine.
Thank you.
Edema. Edema is swelling due to body tissues containing an excessive amount of fluid. It can be local or generalized. A patient may exhibit peripheral edema of the extremities, most often in the feet and ankles. Pitting edema refers to an indentation maintained in the swollen area after being pressed with the finger. It is measured by the numbers 1 through 4, corresponding to the depth of the depression left in the skin. Number 1 means the indentation is barely noticeable. 2 means the indentation is less than 5 millimeters. 3 means the indentation is 5 to 10 millimeters, and 4 means the indentation is greater than 10 millimeters in depth. In severe cases of edema, the skin will appear taut and shiny with weeping of clear fluid, usually seen in small droplets on the skin. It is not unusual for a terminally ill patient to exhibit some type of edema as the symptoms of the body begin to shut down. Lymphedema in the upper and lower extremities is exhibited by painful swelling. The skin sometimes appears slightly red and may be extremely painful to the patient when touched. Lymphedema in the arms and hands is often associated with breast cancer that has metastasized to the lymph nodes or with radiation therapy to the underarm or axilla area. It can also occur after a mastectomy. Lymphedema is caused by an accumulation of protein-filled fluid in the lymph due to damaged or blocked lymph nodes that are unable to perform their task of carrying this fluid throughout the lymphatic system. The lymph that is edematous is highly susceptible to infection, and care must be taken to avoid cuts, shearing, or burns. When caring for my mother-in-law with metastatic breast cancer, she exhibited severe lymphedema in her right arm due to radiation therapy and metastasis to the axillary lymph nodes. She also exhibited lymphedema in her legs due to the tumor in the pelvis. Her right arm edema was controlled for a few months by regular lymphedema massage, by a trained physical therapist, and by a lengthy process of daily wrapping her fingers and arms with layers of soft cotton gauze, a compression stocking, and foam. In her final days, however, this process became more painful than lymphedema itself. At this point, I simply elevated her arm on a soft pillow for comfort. Other causes of edema, excluding lymphedema, may include hyperproteinemia, a disease in the amount of protein in the blood, excessive salt intake, also fluid retaining medications, steroids, nascents, or tamoxifen citrate, sometimes administered for breast cancer, and decreased cardiac output, impaired kidney function, fluid, I'm reading from my phone and it's so tiny, fluid overload from intravenous or tube feedings, see dehydration section below. Phyllipitis, inflammation of a vein, causing localized pain, warmth of the site, and swelling. Cellulitis, inflammation of cellular or connective tissue that spreads through the tissue, causing redness, swelling, and if severe, weeping of fluid through the skin. What can be done? Medications. The physician may consider changing a medication that causes fluid retention. Diuretics are sometimes recommended, depending on the cause of the edema. A potassium supplement may be added to the patient's medication regime, depending on the type of diuretic prescribed. Diuretics will naturally cause the patient to urinate more often, sometimes creating a problem of inconvenience, especially when it disturbs sleep. If incontinence is a consideration, the caregiver will need to pay special attention to skin care, cleansing the patient often and keeping the skin dry. An indwelling urinary catheter may need to be considered when diuretics are used. The catheter helps to keep the skin dry and free from rashes and other irritations caused by urinary incontinence. It also allows the patient to rest without the inconvenience of frequent urination. The main risk of having a urinary catheter inserted is developing a urinary tract infection. Diuretics are not recommended for lymphedema. Antibiotics are sometimes recommended if cellulitis is present. Back to basics. Unless otherwise instructed by the physician, place pillows comfortably under edematous legs and feet, or if a hospital bed is being used, raise the lower portion so extremities are elevated. Either way, the legs should be raised to the level of the heart in order to be effective in reducing edema. Reposition the pillows and the patient's extremities every 2 hours to tolerate, as tolerated, or sooner if the patient desires. If edema is in the hand or arms, as in lymphedema, gently place a pillow under the edematous limb for comfort and to help reduce swelling. Turn and reposition the patient every 2 hours as tolerated or sooner if the patient desires. Consult with the hospice nurse on proper repositioning when lymphedema is present. Decrease any salt when preparing meals. Encourage natural diuretics such as hot herbal tea if tolerated. If taking diuretics, encourage potassium-rich foods such as bananas and orange juice. However, first discuss this with the physician or hospice nurse to see if it is advisable. Increased potassium may be contraindicated in certain conditions such as kidney failure. Advise the patient to avoid sitting upright for long periods with legs dangling. This will increase dependent edema for lower extremities. Ask the physician or hospice nurse if compression stockings are indicated. Fever. A fever is an elevation of body temperature above the normal temperature. In general, a person's temperature is considered within the normal range of it is 1 degree above or 1 to 2 degrees below the normal temperature. Body temperature is usually lower in the morning and higher in the late afternoon or evening. Symptoms of fever may include flushed, hot skin. Skin may initially feel cool at onset of fever. A headache, generalized aching in the muscles and or joints may suggest a viral infection. Increased respiration and heartbeat, increased thirst, decreased urine output, weakness, and chills. Coughing, which produces rust-colored or yellowish phlegm, and or wheezing may suggest pneumonia or other pulmonary infection. Vomiting and other diarrhea when a fever is present may suggest an infection of the digestive tract. Normal oral temperatures are as listed below. Should I read them?
Sure.
Okay, so with an infant, it's 36 to 38 degrees Celsius, 97 to 100 Fahrenheit. A child, 37 degrees or 98.6 degrees Fahrenheit. An adult, 37 degrees or 98.6 degrees Fahrenheit. Elderly, 36 or 98 degrees Fahrenheit. In a patient who is extremely ill, possible causes of fever include infections such as infected wound or urinary tract infection, pneumonia, tumor fever. Tumor fevers are often seen with liver metastasis. Also, tumors in the central nervous system, such as a brain tumor, often cause a persistent fever that is either elevated or remains low grade. Toxic effects of some medications, end-stage disease process. A patient's temperature can be taken orally, auxiliary under the arm, rectally, or by a tympanic or ear thermometer. The oral temperature is the patient's accurate body temperature. However, if the patient is unconscious or is unable to tolerate having a thermometer in her mouth, temperature should be taken either under the arm, rectally, or with a rhythmatic thermometer. From my experience, temperature strip thermometers can be costly, and their accuracy can fluctuate. Mercury thermometers are no longer manufactured in the U.S. However, if you are using one, carefully shake the thermometer so the mercury falls below the normal mark, 98.6 degrees Fahrenheit, 37 degrees Celsius. Wash it with cool water, place it under the tongue, and leave the thermometer in place for 3 to 5 minutes with the patient's mouth closed. For better accuracy, it is best to wait for at least 15 to 20 minutes after the patient has eaten or has had a hot or cold drink before taking any oral temperature. The same applies to the patient if the patient has just had a bath or shower. When taking an auxiliary temperature, place the tip of the thermometer in the armpit of the patient. Then lower the patient's arm close to his side to hold the thermometer in place for approximately 8 to 10 minutes. Add 1 degree Fahrenheit, that's 0.5 degrees Celsius, to convert to the oral temperature. When taking the temperature rectally, insert the thermometer only 1.5 inches with an adult patient and only 1 inch with a child. Hold in place for 2 to 4 minutes. Subtract 1 degree Fahrenheit, 0.5 degrees Celsius to convert to the oral temperature. Digital thermometers are used in the same way as the old-fashioned glass thermometers register in much less time, usually about 1 minute. Pneumatic thermometers are held against the inside of the ear and usually register in about 2 to 3 seconds. What can be done?
I think we have a few minutes left. Maybe we'll let Karunapurna Shakti Mataji read. Thank you so much, Mataji.
Sure.
Acetaminophen, ergo Tylenol or paracetamol, is usually recommended to reduce fever. If the patient is unable to swallow tablets, the physician can prescribe acetaminophen suppositories to be administered rectally. If it is determined that the patient has an infection, such as a urinary tract infection, the physician will probably prescribe an antibiotic. If the patient has an infected wound, a combination of systemic antibiotics as well as wound care with a topical antibiotic may be prescribed. Back to basics. Once it is established that the fever is not caused by an infection, or if the source of infection has been determined and appropriate medications have been prescribed, the following measures can be taken to help reduce the fever. Encourage the patient to wear lightweight, loose-fitting clothing. Unless requested by the patient, do not bundle him under heavy blankets in an attempt to sweat out the fever. Remove blankets and loosely cover the patient with a cotton sheet. Rather than tucking in the sheet, it can be tented by placing the edges over the side rails of a hospital bed. If a hospital bed is not being used, place pillows and drape the sheet over the patient, with the edges of the sheet tented over the pillows. Provide circulating room air. Do not direct the fan or air conditioner directly toward the patient. Provide sponge baths with lukewarm water. See Giving a Bed Bath in Chapter 8. Never use rubbing alcohol on the patient to reduce a fever because it tends to cool the patient's body temperature too quickly. It also has a very strong odor and has a drying effect on the skin. Place a cool, moist washcloth on the patient's forehead. For a fever over 102 degrees Fahrenheit or 38.8 Celsius, place small ice packs on the axilla under both arms and in the groin area to reduce fever. Be sure to cover the ice packs in cotton cloth before placing against the skin. If tolerated, encourage an increase in fluids such as water, juices, ice chips, or fruit pops. As the patient's temperature decreases, he will probably perspire a great deal. Assist in keeping the skin clean and dry. As bed sheets become moist, change them as needed for the patient's comfort. The patient's mouth may tend to become dry with a fever. Using a moist toothette, perform mouth care every 2 hours or more as needed. Should we stop here or continue?
I think we can continue for a few more minutes. Yeah, thank you.
Nausea and vomiting. With a terminal illness, nausea can occur without vomiting, and vomiting may occur spontaneously without warning of nausea. Briefly, there is a part of the midbrain where the vomiting center is located. Here, the brain receives messages from the cerebral cortex, signals anxiety. The inner ear signals vertigo. The chemoreceptor trigger zone signals toxins in the blood, such as chemotherapy and other drugs, and the gastrointestinal tract signals peptic ulcer or other stomach intestinal upset. Causes of nausea and or vomiting vary and may include anxiety, medication reaction, usually with opioids, NSAIDs, antibiotics, estrogens, and chemotherapy, primary brain tumor or brain metastasis, constipation and or fecal impaction, bowel obstruction, motion sickness can occur with inner ear infections, stomach ulcer or gastrointestinal infection, abdominal carcinoma, excessive coughing with mucus production. What can be done? Medications. As a caregiver, keep an accurate record of when your patient experiences nausea or vomiting. This will aid the physician and hospice nurse in evaluating the cause. Does the patient have nausea without vomiting? Does the patient have strong projectile vomiting without warning of nausea? Is the emesis bright red? Is it coffee ground looking material? The latter may indicate a gastrointestinal bleed. Is there a pattern of any sensory stimulation that causes nausea, such as cooking smells, incense, etc.? Are the caregivers turning the patient too quickly, causing dizziness and nausea? Does the patient consistently vomit after taking an opioid for pain? In that case, the physician may adjust the dose or prescribe an alternate pain medication. Similarly, some NSAIDs can cause nausea and vomiting. If this occurs, switching to another NSAID on a trial basis may be helpful because the patient may not react the same to all NSAIDs. Antibiotics given for symptom management, as in the case of a urinary tract infection, can sometimes cause nausea and vomiting. Again, a patient may have this side effect with one antibiotic and not another. If the cause of nausea or vomiting is constipation, a change or an increase in the patient's daily laxative regime may be helpful. If anxiety is so great that it is causing nausea and or vomiting, the patient may benefit from an anti-anxiety medication when anxiousness is at its worst. If a patient's nausea is caused by raised intracranial pressure, as is sometimes the case with a brain tumor, he may benefit from a steroid such as dexamethasone to increase inflammation. Usually the physician will prescribe an antiemetic depending on the cause of the patient's nausea or vomiting. As previously stated, when a patient begins an opiate for pain management, an antiemetic should always be prescribed on an as-needed basis for nausea and or vomiting. A patient may be especially vulnerable to these side effects during the first few days of taking the morphine. In this case, an antiemetic is sometimes prescribed round the clock during the first few days while the patient adjusts to the strong opioid. If for any reason nausea persists and becomes severe, then 2 or more different kinds of antiemetics may be required because each drug will act to subdue nausea at a different site. For example, haloperidol, Haldol, is recommended as an antiemetic when the chemoreceptor signal zone triggers nausea due to toxins in the body. Prochlorperazine, compazine, is recommended for nausea with or without vomiting being present. It also acts on the chemoreceptor signal zone. Prochlorperazine, as well as other antiemetics, are available in suppository form to be given rectally when the patient can no longer swallow medication or is unable to keep it down due to nausea and vomiting. Back to basics. Aside from using the appropriate medications, these suggestions may help provide comfort for your patient. Give antiemetics 30 minutes before meals or as prescribed by the physician. Provide good oral hygiene for the patient before and after meals so the mouth feels clean. That often helps to alleviate nausea. Avoid movements that produce nausea. Do not serve foods with harsh smells, such as cabbage, that may exacerbate nausea. When someone is nauseous, even subtle odors can cause one to become ill. Prepare bland foods and clear liquids until the nausea subsides. Offer small meals rather than large, hearty meals. If the patient is vomiting with nausea, ask the hospice nurse or physician for diet instructions. Keep a cup of small chipped ice by the bedside with a teaspoon. If the patient is weak, offer to feed her only 1 or 2 small ice chips at a time. This will help prevent dehydration. Sometimes small sips of clear carbonated soda or carbonated water can be tolerated with nausea. This will also help avoid dehydration. Be aware that fragrant candles, incense, or fresh flowers can cause the patient to experience nausea. Provide dim lighting when the patient is feeling nausea and/or vomiting. Provide a relaxed environment by decreasing environmental stimuli. Encourage the patient to rest after meals. Provide good oral hygiene for the patient throughout the day, especially if the patient is experiencing a dry mouth with thick secretions. Remove any unsightly items in the room, such as a bedside commode, to create a more pleasant atmosphere during meals. If your patient begins to vomit while lying on his back, immediately roll him over to a side-lying position so the contents are not aspirated into the lungs. If possible, assist him into a sitting position with head bent slightly forward.
Thank you.
Hare Krishna.
Thank you. Wonderful. Everyone, thank you for reading so wonderfully. And we'll continue next week. And we're also planning to have a deep dive workshop in beginning of March. So the information will come out soon. I know we promised that a few months ago, but it never happened. But this time it will happen by Krishna's mercy, and in the beginning of March. So yeah, we're looking forward to that. And we'll see you next week. Hopefully Sangeeta Mataji will be able to join as well. Thank you, everyone. Stay.
I
just
Thank you
say
so much.
that
Hare Krishna.
Hare
Thank you.
Krishna. Thank
Hare Krishna.
you.
Thank you.
Hare Krishna.
Keep up your good work. Thank you.
Thank you.